Abdominal pain. It sounds simple, but the textbooks are filled with all sorts of rare, juicy diagnoses. Let's talk about what's actually important when you see a patient with abdominal pain. When I was a medical student, I'd jump to rare diagnoses, like when my cousin in Europe said he had abdominal pain, and I blurted out, maybe it's familial Mediterranean fever. We've all been there, lost in the haystack of rare textbook cases. But most of the time, the answer is simpler. The challenge is cutting through the noise and finding the real issue. So what do we actually do? First, divide the abdomen into 4 quadrants. Each one has its usual suspects. Right upper quadrant, think biliary colic or cholecystitis. Right lower quadrant, appendicitis or ectopic pregnancy in women of reproductive age. Left lower quadrant, diverticulitis or, again, ectopic pregnancy. Left upper, maybe splenic rupture and trauma, but otherwise not much. Epigastric pain, peptic ulcer, or even a perforated bowel. Generalized pain could be perforation with peritonitis, pain radiating to the back. Watch for abdominal aortic aneurysm or pancreatitis. Flank pain could be pyelonephritis or kidney stones. It might seem oversimplified, but this approach really works. Also, if there's no bowel movement, think about obstruction or paralytic ileus. So, what do we do when a patient comes in? Start with the basics: analgesia, IV paracetamol, IV algapyrin, IV PPI, antiemetics, ondansetron or metoclopramide, IV fluids, because they might need surgery and are often kept kneel by mouth. Worried about cancer? It usually doesn't cause abdominal pain, but I'll show you a trick to catch it anyway. After examining and giving meds, get bloods. Add amylase or lipase for pancreatitis. And beta-HCG for women in reproductive age. Always don't mind if they say, "Oh, I am sure I am not pregnant." Loads of times I revealed to them in shock that they are pregnant. Next, imaging. CT is best, especially with contrast. Sometimes we start with ultrasound. The scan is your crystal ball. It tells you what's really going on, even more than the physical exam. Radiologists often say, "You examine the patient. We'll tell you the diagnosis." And honestly, they're not wrong. If a patient has severe pain out of proportion but no obvious findings, check a VBG and lactate for ischemic bowel. But remember, sometimes the lactate is normal. Even then, don't rule out ischemia. Depending on the scan and labs, refer to surgery, gastroenterology, or sometimes just discharge if nothing is found. Sometimes everything is negative. Labs, scan, everything. Could it be psychological? Maybe. But it's not always classic stress or panic. Some people just have psychosomatic pain. If all tests are negative, reassure your patient. And remember, gastritis and peptic ulcer disease might not show up on scans or bloods. If it's epigastric pain, a trial of IV PPI can help. To sum up, use the quadrants, start simple, give pain relief and fluids, order the right tests, and remember, if everything is negative, reassurance goes a long way. Thanks for watching.